Hi, everyone. Can you hear me okay? We've got the mic down here. Okay, fantastic. Thank you for being here so early on day 2 of this amazing conference. I'm Sarah Victor. I'm one of the co-chairs of this session with Kate Mouloud. Here to talk about disability as an identity and mental health and well-being correlates and implications for future research. So really what we're going to do is just kind of launch in to our talks. I'm going to get us started. And tell you a little bit about disability among psychology faculty and trainees. Just as a heads up, we are recording the presentation so that we can disseminate them outside of ABCT with approval from the conference. When we do Q&A, we'll make sure that the video recording is facing us. As I said, I'm Dr. Sarah Victor. I'm an assistant professor at Texas Tech University, where my research includes focus on self-injurious thoughts and behaviors, and more recently, lived experiences of mental illness and psychiatric disability among psychologists. And so for the purposes of this presentation, I'm going to talk to you a little bit about prior work and our own data on disability among what we're calling applied psychology faculty and trainees, so clinical counseling and school psychology fields. Not to say that other fields do not have applications, but the fields that can lead to licensure in clinical practice. So we know from prior research that people with disabilities are underrepresented among university faculty. They're underrepresented among practicing psychologists and among trainees in clinical counseling and school psychology. Interestingly, our work in looking at mental health problems, which can include diagnosed mental health conditions, are very common among applied psychology faculty and trainees. And yet, we know that certainly not all mental health conditions are disabling or meet the sort of typical definition of disability. And even for folks who experience impairment associated with their conditions that could sort of fall under that category of disability, not everyone identifies as disabled. So we thought, well, we need some more research to kind of look into this and understand both the prevalence of indicating a disability in this population and the intersection with psychiatric conditions assessed separately. So these data are drawn from a really large sample of applied psychology faculty and trainees. The way that we did this survey was we pulled a database of all accredited US and Canadian clinical counseling and school psychology doctoral training programs. There's a lot of them. This also includes doctoral internships. And this also includes combined programs like clinical counseling for the school. We used a standardized way of training research assistants to pull information from department program websites to pull all available email addresses for anyone affiliated with these programs. I'm just going to do this. Sorry, I've got the recording sort of jury-rigged over there. We sent this survey out because we wanted to avoid sort of relying specifically on snowball sampling, knowing how many times directors of clinical training get emails to send out surveys. So we just sent it out ourselves to as many people as we could find contact information for. About 9,000 emails went out. And we described the survey as assessing research and clinical interests in order to avoid sort of oversampling for people who would describe themselves as disabled or as having lived experience of mental health conditions, even though we were, of course, very interested in that. We asked people about whether they had ever had a disability in the demographics portion of the survey on page 2 or 3. And this was just a yes, no. And then we said, you can fill in the blank if you want to tell us about either the type of disability or specific disability you have. Then later in the survey, we asked 2 questions. Have you ever had a mental health difficulty? We left that very broad. And then have you ever been diagnosed with a mental health condition by a professional? So more narrow. Overall in the sample, about 80% said yes to the first question, about half of the sample said yes to the second. And so we then looked at associations between reporting yes for disability, demographics, mental health difficulties, and professional problems related to mental health. So in our sample, about 21% said yes to the disability question. In terms of demographic distribution, we didn't see significant differences when we compared non-Latinx or non-Hispanic white individuals with members of all other racial or ethnic groups. Important caveat here is that the cell sizes for specific racial and ethnic groups in some cases were quite small. So we weren't adequately statistically powered to look at more nuanced differences, which descriptively, if you just look at kind of the crosstabs across racial ethnic groups, do look like there could be differences, but I don't want to overinterpret those given the cell sizes. In terms of gender, we saw the highest reports of disabilities among folks that identified as trans or non-binary, with, of course, a little asterisk, but that's only about 33 people. When you look at cisgender women compared to cisgender men, you see a slightly higher rate in cisgender women. Did see higher rates in LGBTQ respondents compared to heterosexual individuals, and a higher rate, about twice as high, in graduate students compared to faculty. When we looked at age, it was important to look at this separately for graduate students compared to faculty. Graduate students have a much more restricted age range. We didn't see an effect for age for graduate students, but we did see an effect for older age in faculty. Among respondents who said yes to the mental health difficulties item, about a quarter said, yes, I have a disability. If you sort of look at the flip of that overlap among those with disabilities, almost all, 96%, said, yes, I have had a mental health difficulty at some point in my life. Among folks with mental health diagnoses, you see a little bit of a shift here where about a third say, yes, I have a disability. And among those with disabilities, about 84% say, yes, I've been diagnosed with a mental health condition by a professional. Now, it's of course important to recognize that the disability item incorporates a huge range of disabilities, right? So in some ways, this overlap captures the extent to which people with potentially disabling mental health conditions identify as disabled. To some extent, it also captures mental health comorbidity among people with other types of disabilities, such as sensory disabilities, mobility impairments, etc. So that's just an important caveat here. And so then we thought, well, okay, we asked folks who had mental health difficulties or diagnoses, have you ever had professional problems related to your mental health? Which is often a criterion you would think about in terms of disability identification. In terms of the folks who said yes to mental health difficulties or diagnoses, about half said no professional problems related to it. About 40% said yes, it's caused some mild problems at some point in my work. And about 12% said moderate or severe problems. When you look at those who reported moderate to severe problems, a little over half said, yes, I have a disability. Among those with mental health difficulties, we saw that disability was associated with a greater total number of specific mental health difficulties reported. So for people who said yes to the original item, we gave them a long list tied to as many DSM categories as we could: depression, bipolar, specific phobia, generalized anxiety, and on and on and on and on. There are about 30 options. So their total number reported was higher. That was also the case when we looked at just difficulties that people said were currently an issue for them, as well as when we said difficulties in the past. We also took a look at those specific difficulties to see if endorsement of specific mental health concerns was associated with disability identity. When you look at those in just a bivariate table, almost all of them are associated with higher odds of reporting a disability, which makes sense if the people who say yes to the disability item are also reporting a higher number of conditions. So then we went back and said, well, what if we control for total number of mental health difficulties? Do we see any specific associations? And we did see a couple in different directions, which I thought was interesting. So social anxiety disorder and body dysmorphic disorder, when controlling for total number of difficulties, were actually associated with a decreased odds of saying yes to disability items, whereas having a specific learning disorder or a diagnosis of ADHD were associated with increased odds of saying yes to the disability item. So in terms of our take-home messages, it certainly suggests that disabilities are common among applied psychology faculty and trainees, and we certainly see that this identification intersects with other aspects of one's identity related to sexual orientation, gender, that might be marginalized or underrepresented or minoritized in the field. Certainly we see an association between disability identification and reports of mental health difficulties, which of course has implications for how we need to improve our training and our essentially cultural competence to provide services, mental health services to disabled people. And that we have this sort of interesting discrepancy where even folks who report, diagnosed mental health conditions that have caused moderate or severe work impairment aren't necessarily identifying as disabled, which can have implications for making sure that appropriate accommodations are accessible to folks who may not sort of think that disability accommodations are relevant for them, as well as kind of approaches to advocacy and community building. Of course, I want to thank my participants, without whom we could not have done this work, and other members of the research team who were involved in this larger project. And with that, I will try to end quickly so we can have as much time as possible for everyone else. Thank you so much. I think next up, we're going to have a presentation from Jennifer Perlstein, which Peyton will introduce.
Thanks, Sarah. I'm Peyton. I'm the other co-chair for the symposium. And our next speaker is Dr. Jennifer Perlstein. Jen Perlstein just completed her postdoctoral fellowship at the University of Washington in rehabilitation medicine, and will soon begin as an assistant professor at Washington University in St. Louis. Dr. Perlstein's research focuses on disability identity, emotion, stress, and psychopathology. And in addition to research, she strives to improve disability inclusion and mental health care through clinical practice, writing, and advocacy. And she was unable to be here because she is currently taking care of her newborn. But we're really excited that she was able to record her presentation as well.
Hey. My name is Jennifer Perlstein, and today I'm going to be presenting with you my research related to disability identity, depression, anxiety in people with visual impairment and blindness. I am saddened that I'm not able to be there with you all in person. It is for an exciting reason. I just had a baby and I'm unable to travel. However, I am glad that I'm able to share this recording with you, and I hope to continue the conversation offline and not in person at the conference. So before I jump in, I did want to give some access to learn more about the research that I'll be presenting with you all today. I have included on the screen here QR codes, both for the published results that I'll be sharing, as well as for the slides. And I will show these again at the end of my presentation so that you're able to access this information on your own device or after the conference, as it would be helpful for you. I want to start off by sharing a bit about my positionality. Positionality refers to who we are and the lens through which we do the work that we're doing. And I think especially in the context of doing research related to vulnerable or marginalized populations, this is a really essential conversation for us to have. So I want to share that I am a white cisgendered woman who identifies as heterosexual, and I do identify as a member of the disability community. I am blind with low vision. For those who care about visual descriptions, I have reddish-brown curly hair, white skin, and I am wearing a black sweater with kind of a vibrant necklace. I want to start by providing some background information about blindness and visual impairment, especially as it relates to mental health. Estimates of how much of the population experiences blindness or visual impairment varies based on the precise definition of blindness or visual impairment being used. However, approximately 4.2% of the population is impacted by this. And understandably, adjusting to blindness and low vision does have impacts on mental health. While many people adjust with resilience and experience positive mental health in the context of these disabilities, it's also quite common for people with blindness and low vision to experience depression, anxiety, increased loneliness, isolation, and other poor mental health outcomes like heightened suicidality. Questions remain, though, for whom and why these poor mental health outcomes show up for people with blindness and low vision. There are a number of hypothesized reasons. It is likely that difficulties such as lack of access or lack of inclusion related to ableism or discrimination and prejudice may be critical factors. Additionally, it can be difficult to communicate related to blindness and low vision. These conditions can also present with pain and ocular discomfort, and understandably, there are some affective consequences like increased frustration or experiences like loneliness that can come about as a result of experiencing blindness or low vision. While many of these may be contributing factors to heightened rates of depression and anxiety, the factor that I am interested in sharing with you all a bit more about is disability identity. Disability identity refers to one's self-concept as a person with a disability. There are a number of different ways in which disability identity is operationalized and measured. Key constructs that are associated with disability identity include pride, affirmation, personal self-meaning, self-worth, group affiliation or identity, so the extent to which someone feels connected to the broader disability community. There have been a number of research studies to date that have shown that disability identity appears to be protective in the context of mental health. People with higher or more robust forms of disability identity do appear to have more positive mental health experiences, increases in well-being, and decreases in depression and anxiety. For the study that I'll be sharing with you about today, I was interested in looking with my co-author at two novel constructs of disability identity, specifically personal disability-related self-worth and personal meaning. And I'll share a little bit more about how these are measured in the methods, but the key idea being is that these are aspects of one's attitudes towards oneself as it relates to being a person with a disability. So the key question that we're interested in answering here is how these two sub-constructs of disability identity, personal disability self-worth and personal meaning, how these relate to experiences of depression and anxiety as two key mental health outcomes in populations of people with blindness or visual impairment. A bit about the participants in the procedures. The sample used was an international sample of people with blindness or visual impairment, and we did not limit the amount of vision loss required for participation or the level at which vision must be for participation. So we do have kind of a wide gamut of experiences in the current data set. The population sampled is predominantly white, and while we were collecting an international sample, most were from westernized and industrialized nations. So these are important considerations in thinking about the generalizability of our results. We had participants complete an online survey battery, and I'll explain more about those measures in a moment. And then based on the data that we collected, we conducted hierarchical linear regression models to look at the relative contributions of demographic characteristics, disability-related characteristics, and disability identity in predicting depression and anxiety. So about the measures, we used a novel conceptualization of personal disability identity that has now been pretty widely used by Mercedes Zapata, my co-author and collaborator in this work. And the two specific scales that we were most interested in were disability-related self-worth and disability-related personal meaning. So these correspond to how much someone believes that they have value or worth as a person with a disability, as well as the extent to which experiences related to disability contribute to one's overall kind of perception of life and of kind of the broader world. In addition to disability identity, we did have people self-report on demographic characteristics like age, gender, employment. We also looked at disability-related characteristics such as level of functional vision, use of mobility aids, whether or not other family members have the same disability. And then we did measure depression and anxiety using a very brief 4-item version of the patient health questionnaire. So let's talk about what we found. We used a hierarchical model where we entered 6 demographic-related factors in Block 1, 6 disability-related factors in Block 2, and then the disability identity-related factors in Block 3. I'll show the results from the full hierarchical regression model on the next slide, but I wanted to provide the summary here, which is that we found that age, gender, and disability identity, specifically that self-worth measure, were predictive of depression and anxiety, such that being older, being male, or having higher disability self-worth related to having lower levels of depression and anxiety. Here's what those results look like here. We only show the variables that presented as significant in each of the blocks. Otherwise, there would be way too many variables presented on this screen here, but you can see those key findings that I summarized a moment ago. So let's talk about these findings and how these are relevant for our clinical practice. As hypothesized, we found that disability-related self-worth was a significant predictor of mental health outcomes, specifically depression and anxiety in an international sample of people with blindness or visual impairment. Notably, disability-related self-worth was the strongest predictor, so it predicted more variance than any of the demographic or disability-related factors that we considered. This is really exciting and important because it means that we may have an ability to modify mental health by shifting attitudes related to disability experiences. And for those of us who are cognitive behavioral therapists, this is really excellent news. We can shift attitudes about oneself related to being a person with a disability that may have really beneficial outcomes for mental health. Now, the specific mechanisms by which this happens is not fully understood. Some ideas, though, are that when we have higher self-worth as people with disabilities, we are more likely to engage in prosocial activities, to connect with the disability community, to be less likely to be isolated, may diminish loneliness. It also may have some very important affective consequences, like increases in disability joy, but also decreases in feelings of shame, guilt, embarrassment, frustration. And of course, these are all possibilities that I am eager to explore further to better understand why disability identity is protective for mental health. Which brings me to some exciting future directions that I intend to take this work in. I'm excited to look at disability identity in additional populations beyond those with blindness and visual impairment. I'm currently doing research in a population with multiple sclerosis, and I'm eager to explore additional conceptualizations of disability identity as well, since there are many facets to this way of measuring self-concept as a person with a disability. I'm also interested in considering other contextual factors that contribute to mental health for these populations. More specifically, I'm interested in the unique stressors faced by people with disabilities, including ableism and other forms of systemic oppression that are likely contributing to mental health experiences. And finally, I'm eager to explore additional mental health outcomes. We were limited to only use a 4-item, really crude measure of depression and anxiety in this study, and I'm eager to explore diverse forms of psychopathology, as well as additional measures of well-being and quality of life to better understand these relationships. With that, I want to remind you all of the resources I shared at the beginning. If you are interested in learning more about this work, please feel free to look at the article or take this slide deck. And with that, I also want to thank you all and ask you all to reach out to me with any questions, feedback, concerns. I am disappointed that I can't be in conversation with you all in the room today in Seattle. I really do want to hear your responses and continue the conversation. So I've included my email address and my Twitter account on this slide. And I also want to put in a quick plug for the Disability Advocacy Research Network. Kathleen Bogart and others have pioneered this group to connect disabled scholars, disabled researchers, and those who are interested in this type of work so that we can build a community and share ideas with one another. There are a number of subgroups associated with DARN, but I am working on launching a new health service provider subgroup. So if you are a health service provider or you're interested in disability-related research, please do use the link on this slide or reach out to me. I'd be happy to get you connected. With that, I do want to close with an additional thank you to you all for your attention. And I want to thank the panelists. This is such a great panel to see. I'm really excited to be in partnership with Sarah and Peyton and Lauren and Jessica to share about disability and how it impacts mental health. So thank you all for your time and attention. And I hope you all enjoy Seattle.
Well, hi, I'm Peyton. I'm a postdoc at Washington University. And today I'm really excited to talk with you about a project that I've been working on with my research mentors and collaborators on a new physical disability identity scale among people with physical disabilities. But before I get started, I just wanted to give a quick reminder. I have a QR code up here that will link to the slides. It's easier for any of you to access that on your own device. And that same QR code will be in the bottom right-hand corner of each slide if you want to access it at any point. And so before I get started with the actual research, I just wanted to tell you guys a little bit about why I am so just excited and passionate about disability identity research. I was born with a physical disability, and for the first 7 years of my life, this was really how I viewed myself. I refused to see myself as disabled. I really saw my disability as a deficit and something that I wanted to separate and hide from myself as much as possible. But one day, my parents decided to send me to a summer camp for kids with similar disabilities. And while I was there, I met a lot of kids who did share my own perspective of disability, but I also met a lot of kids who seemed to conceptualize their disability as a part of themselves, or what I now know of as disability identity. And even more surprisingly to me at the time, the people who had that really high disability identity seemed to be even happier potentially than the people who conceptualized disability like I did. And so my experiences at camp have really stuck with me and informed a lot of my research questions that I ask and the methods that I use. And so broadly, I'm really interested in mental health and well-being among people with disabilities. And so if we look at prior research, like Jen mentioned, individuals with disabilities often report lower mental health and well-being than individuals without disabilities. But prior research also shows that this concept of disability identity may be helpful for promoting mental health and well-being among people with disabilities. And given my prior experience with physical disability, I was really interested in diving deeper into this concept of disability identity, but specifically among people with physical disability, or what I'll refer to as physical disability identity. And so this current study, what we wanted to do was to develop a new scale that could measure physical disability identity, and specifically one that would capture the multidimensional nature of physical disability identity, and also a scale that would align with the lived experiences of adults with physical disabilities. So as a first step, we set out to create a scale to measure physical disability identity. And to do this, we actually adapted the multi-component in-group identification scale by Leach and colleagues. And we chose this scale. This scale is kind of a general identity scale. It hasn't been used in disability research specifically. But we wanted to use the scale because we thought that it would allow us to capture this kind of multidimensional nature of physical disability identity. And we thought that was important because, if you think about it, there may be different aspects of physical disability identity that are differentially associated with mental health and well-being. So we really wanted to look at that. And this scale also allowed us to address social membership, which we thought was important for viewing physical disability as an identity. And so we reviewed items in the scale and revised as necessary to capture physical disability identity. And we were left with 25 items from our initial pool. We then administered those items to 104 US adults who self-identified as having a physical disability. Our sample was around 50 years old on average, about even split female-male, majority white. The average age of disability onset was around 30 years old, and most people reported first identifying as disabled around 40 years of age on average. And we had participants take an online Qualtrics survey where we had them complete this new physical disability identity scale, as well as assessments of their perceptions of the scale, and also a bunch of mental health and well-being measures. And so after we created the scale, we really wanted to gain some more insight into, what factors are making up this scale? What is the factor structure? And so to do this, we conducted exploratory factor analysis. And this analysis suggested a 6-factor structure from the measure. And so we went ahead and came up with labels for each factor that we felt really kind of comprehensively captured the items that made up that measure, that factor. And so I'll walk through them now. The first factor that we found was connection. So kind of how connected do people feel to others with physical disabilities? And an example item for that was, I feel connected to other people with physical disabilities. The second factor was satisfaction. So how satisfied are you with being a person with physical disability? And an example item for that was, overall, I'm glad to be a person with a physical disability. The third factor was centrality. So how central is your physical disability to your identity? And an example item, being a person with physical disability is an important part of how I see myself. The fourth factor was openness. So how open are you regarding your physical disability? In an example item, I feel comfortable talking about my physical disability with others. The fifth factor was individual self-stereotyping as a person with a physical disability. In an example item, I am similar to other people with physical disabilities. And the sixth factor was disability lens. So, what is the lens through which one views the impact of their disabilities having on their life? And an example item, being a person with a physical disability shapes how I see the world. And so after we kind of explored this factor structure, after we gained some more insight, we really wanted to make sure that the scale was actually capturing the lived experiences of adults with physical disabilities. And so we set out to solicit some feedback on this scale. And we did that by, after participants filled out this new physical disability identity scale, we asked them two open-ended questions. We asked them, are there any items in this measure that you think are difficult to comprehend and interpret? And also, are there any aspects of physical disability identity that you feel are missing from this measure? And we found that, on average, people with physical disabilities, their perceptions of this new scale were actually very positive. And so about 98% of participants reported that there were no items that were difficult to understand and interpret. And about 3/4 of participants felt that the scale comprehensively captured their experience. And I think it's important to note here too, that even though around 25% did report aspects that they felt were missing from the scale, most of the things that they were reporting were specific challenges related to their physical disability. So things like finding a job, getting accommodations, things like that, and not necessarily aspects of identity. And so after we had this scale and, we knew that it aligned, we had evidence that it aligned with the lived experiences of adults with physical disabilities, we really wanted to use it to examine the relationship between these different factors of physical disability identity and mental health and well-being. So we conducted correlational analyses, and I know I always get overwhelmed when people show tables and the results. So I'll point out a couple really specific things that I think are kind of interesting. But just to orient you to the graph, the top row is the 6 physical disability identity factors. And then the first column is the mental health and well-being constructs that we measured. And there were a couple things that we found that were really interesting. So the first one being that we found that the satisfaction and openness components, those factors of physical disability identity, were the most related to mental health and well-being. And so people who reported greater satisfaction or greater openness generally reported, a higher sense of purpose, lower depression, and lower stress. And those who reported greater openness also reported lower anxiety. However, it wasn't a straightforward thing that all of these factors seemed to be, positively related to well-being. We actually found that there were a few factors that, were associated with increased anxiety. And so here you can see centrality, individual self-stereotyping, and disability lens. People who are higher in those also reported more anxiety. And so this just provides some evidence that the relationship between physical disability identity and mental health and well-being may really depend on what factor of physical disability identity you're looking at. So where do we go from here? We actually just conducted a second study, which provided, with a larger sample that reported support provided some support for these findings. So we found some support for the factor structure as well as a lot of the correlations that I just showed you. So one future direction that I think is really exciting is intervention work. And so our results really suggest that there are certain factors of physical disability identity that may be really important for mental health and well-being. So specifically satisfaction and openness. So interventions aim to increase those factors of physical disability identity may be helpful for promoting mental health and well-being among people with physical disabilities. And as I've gone through this project, I keep coming back to my experience at CAM. And, even though it wasn't a formal intervention, I think about the impact that experience had on me and how it really increased my own openness and satisfaction. And so I'm just really excited to continue with this line of research and hopefully, use some of this to help promote mental health and well-being among people with physical disabilities in the same way that CAM did for me. And I just want to give a huge thank you to all of our study participants, the ABCT conference organizers, my awesome supportive research mentors and collaborators, Dr. Patrick Hill, Dr. Emily Ora, and Dr. Kaylin Ratner. And thank you to all of you guys for listening.
Wonderful. Thank you so much. So next we will have Dr. Lauren Clausen, who is a research assistant professor at the Ohio State University Wexner Medical Center in the Department of Psychiatry and Behavioral Health. And Dr. Clausen's research is focused on identifying unique drivers of suicide risk in the disability community among veterans and military personnel. Dr. Clausen integrates these findings into clinical research with the goal of improving efficacy, accessibility, and reach of suicide prevention assessments and interventions for these populations. So we're very excited to have her here.
All right. Thank you so much for the lovely introduction. I'm so excited to be here. And I'll say over and over again, I was looking through the conference program and I would come across these interesting talks and be excited, it's a disability talk. I realized it was my symposium session. So I'm okay, I'm in the right place. But yeah, so I'm excited. I'm just going to go ahead and
Great.
Okay, so today I am presenting on some findings from a pilot trial I've got going on, focused on a brief CBT for suicide prevention among the disability community. And I want to start off by saying, in terms of positionality, the perspective that informs my work is I am also a low vision / legally blind woman. And so what that means is, it impacts how I view the work that I do. I like to think it also gives me a bit of a blind street cred with some of my participants, which I think is really invaluable as well. So I just want to start off by mentioning that the disability community comprises about 27% of the US population. So it's about 1 in 4 people in the US. And when we look into the suicide prevention or the epidemiological statistics related to that, my research and research of colleagues at a more national level find that people with disabilities are up to 3 to 4 times likely to have made a suicide attempt in the past year. One study I cite quite a bit really demonstrates that those odds go up to about 8 times as likely if individuals have multiple disabilities. And among the disability community, we see these consistently high odds across suicide-related outcomes. So this means higher odds of suicide ideation, higher odds of planning to make a suicide attempt, and higher odds of attempting suicide within a 12-month period compared to people in the US without disabilities. And one study that I cite quite a bit, I talk about in just about all of my talks by my good colleague, Emily Lund, is that really suicide is seen as more acceptable for the disability community than people without disabilities. So in this study, they had a bunch of undergraduates read some vignettes related to someone with a disability, someone without a disability, who was thinking about suicide. In one instance, maybe someone was, got a bad grade or had difficulty, was struggling and might not gotten into, they were concerned about getting into med school, something like that. And the participants had to rate whether they thought how acceptable it was for them to make a suicide attempt or die by suicide. They would read another vignette about a student who maybe was going blind or had some sort of other disability that was impacting them. And med school might not have no longer been an option. So the students had to rate how acceptable it would have been for them to die by suicide. And like I just mentioned, suicide was perceived as more acceptable for the hypothetical person with a disability. But the kicker for this study that I really want to stress is that when the participants in the study had disabilities themselves, they still rated the suicides for the people with disabilities and the vignettes as more acceptable. So what this is really pointing to is this possibility that there are some sort of internalized states happening. What they are, research has really started to uncover quite a bit. And of course, we've got internalized ableism, but what else might be happening here? So this is where some of my previous research comes in. This was funded by the Military Suicide Research Consortium as well as the American Psychological Foundation. I wanted to know a bit about these cognitive drivers that underlie the disability community's thoughts of suicide or perceived likelihood of thinking about suicide in the future or attempting suicide in the future, regardless if they've ever had a suicide attempt or not. And what I found here is that really these beliefs about felt stigma or these fears of being discriminated against, treated badly because they have a disability, or worried that envying people with quote unquote normal bodies really impacted or indirectly led to these perceptions of being more likely to think about suicide and attempt suicide in the future. But really, it was indirect through these beliefs of being a burden to others. So these beliefs of perceived lonesomeness. I'm a burden to the extent that others would be better off if I were dead. And my research consistently finds that perceived lonesomeness is heightened among the disability community compared to people without disabilities, and is also a driver of suicide ideation. I found that in every study I've done so far. One thing I also want to note here is there's this idea that the disability itself that someone may have, or impairments that someone might have, really are direct contributors to suicide risk or contribute to suicide risk. This study right here actually found that is not the case. So individuals, I looked at, did people have difficulties in participation in different domains of life? Getting around from point A to point B with a mobility aid or not, or having difficulty in making decisions, cognitive independence, being socially integrated into a community. What I actually found is none of these things impacted this relationship. What it really came down to were these beliefs of felt stigma, perceived burdensomeness, these cognitive drivers of suicide risk here. I also noted that in another study I recently published, we don't see any differences by congenital or non-congenital disability status. And those, that stuff didn't really make it into the final manuscript because I was asked to cut it for space. But what we're finding here is that what is commonly thought when we think about disability, and even maybe disability and suicide, is that disability itself is not a driver of suicide risk. There is something else happening here, some internalized states. And I'll also note is that we don't see significant differences in suicide ideation and attempt history by disability type. So I wanted to note that too, because sometimes there's this idea that one disability, people with disabilities may be at risk, more at risk of suicide or have worse outcomes than people with other disabilities. But when we think that way, we're not really looking at the disability community as a whole. And my research, again, is indicating that that might not be the case anyway. So I'll also note that in terms of suicide prevention research, there are no clinical trials that have happened focusing on suicide prevention interventions for the disability community. None. So I received some funding from the American Foundation for Suicide Prevention to conduct the first one. And this is an adaptation of brief cognitive behavioral therapy for suicide prevention by Ryan Rudd. And so this is an intervention that is 3 phases, 12 sessions long. And it has, it's very much incorporates your traditional CBT elements as well as behavioral skills. So for folks who aren't familiar, I'll just do a quick overview here. Where the first phase of BCBT focuses on emotion regulation skills. So there is, on the left here, I've got examples of what's called a crisis response plan, which is part of that. But also we're really focusing on skills to help people regulate emotions, so that way they can access their more cognitive reappraisal types of skills. So that's about 5 sessions for phase 1. Phase 2 is roughly about 5 sessions as well. And this is your traditional cognitive behavioral therapy, like cognitive restructuring skills that we go through with folks. Targeting these beliefs, these core beliefs that maintain heightened suicide risk and especially pop up during periods of acute risk. Finally, the last phase, phase 3 of BCBT, is focused on relapse prevention, where if anyone does prolonged exposure and you sort of like imaginal exposure exercises with clients here, this is a similar thing where we have individuals imagine the details of a last suicidal crisis. It tends to be the one that brings them to treatment. And they now imagine themselves using the skills to resolve the crisis, the skills that they learned in treatment. And once folks are able to resolve the crisis using their skills, they successfully completed BCBT. So basically in this study, I wanted to know, what if we adapt BCBT for the disability community? Do people with various physical or disabilities experience significant reductions in suicide ideation, perceived burdensomness, and overall suicide-related cognitions that tend to maintain acute suicide risk? So in this study, what I am looking at, because it is currently ongoing, about halfway done, we're administering BCBT through telehealth for at least 12 sessions. And we're using a disability affirming approach here to 60 people that have hearing, vision, dexterity, and mobility related disabilities, where we are making sure everything we are doing is accessible. So the modality, the worksheets, the handouts, how we assign the skills is really tailored to meet the needs of the patients. And we're focused on building a positive disability identity as well. So again, not seeing disability as a deficit, but thinking about the disability community as a minority group with shared values, shared strengths, and shared experiences, just like Dr. Perlstein had talked about in her work. And really targeting those disability-related cognitions that maintain suicidality, especially perceived burdensomeness. So like I said, we're about halfway done with the study, but we're still recruiting. And I know these are probably going to come up really tiny. Not great, but okay, I'll explain them anyway. In this preliminary sample of 34 who have completed at least 1 session of BCBT, with these sessions approximately administered once a week, our racial demographics are better than what I've been seeing in my previous research. It's still over 80% white sample. We are seeing more Black African-American participants here, with about 15%. And in terms of gender, what I'll note is it is, again, primarily women who are in the sample, but a little over about 12% of people fall outside the gender binary. And in terms of disabilities, most people do have a mobility-related disability, with multiple sclerosis and spinal cord injuries being most common. We have a good number of folks who come in who have visual-related disabilities, low vision, blindness, complete blindness who've come in. And it's, I'm really excited to also report that one thing I found is that half of the sample identifies as LGBTQ+. So combining that with the folks outside the gender binary as well, we really have a large queer sample, even though that wasn't something I was recruiting for. I think it is really noteworthy to note. And in this study, what we did is we had folks complete weekly assessments. So they completed the Beck scale for suicide ideation before every session. And then they also completed at beginning of treatment at baseline, session 5, which corresponds about to the halfway point of treatment, and at treatment completion, the interpersonal needs questionnaire and the suicide cognition scales to assess those cognitive states. So when we think about the results here, I'm excited to how things are looking. So first off, when we think of SI scores over a weekly period, we're seeing significant decreases in mean scores by session 7. So a little around the halfway point, a little further than that. And these are, overall the trend is continuing through session 12 with a decrease of about almost 5 points on average. What I'll note is there are the dashed line at the bottom where it looks like folks are just completely dropping off toward the end here. These are participants that needed more than 12 sessions to complete all the skills. I basically left it up to the therapist to decide how many sessions participants need because it's open trial here. So we had a couple of folks that went out 14 to 16 sessions. I think the end was 2. We just needed a little bit more. And we can see by the end, they did fantastic. So I wanted to stress it doesn't mean that everyone needs 16 sessions of ABCT, but the folks that did really well by the end of treatment. So we have our SI scores that have significantly decreased. Same thing with our suicide-related cognitions. These are ones related to unlovability, we call unbearability and unsolvability. We see mean score significantly decreased by a little over 5 points from baseline to session 5 here, and during that first phase of treatment, which is that emotion regulation phase. And then by additional 5.43 points from session 5 until treatment completion. So a little bit more during that second phase, which makes sense because that's the cognitive flexibility phase of treatment. Good news for perceived burdensomeness as well. We see the same trend. However, the gains tend to be maintained from session 5 to treatment completion. So we see that significant drop in points from baseline to session 5, and then kind of a maintenance effect happening toward the end with a slight drop. So let's talk about implications and next steps, or really ongoing steps for this work. So I just want to note, our significant reductions in suicide-related cognitions, perceived burdensomeness, are happening pretty early on. So from a cognitive, behavioral kind of conceptualization standpoint, and which is in line with how we conceptualize doing BCBT, it might mean that people, once they are being able to regulate emotions, are able to access their cognitive reappraisal skills early on their own, before we even teach these skills. And then once we teach them, we're able to continue using the skills on their own with maintenance effect. And so BCBT is also demonstrating promise in reducing suicide ideation in the disability community. Because it's a small sample, we're not looking at behaviors, or I should say I'm tracking them, but it's not necessarily the outcome of interest because this is a small pilot and study. But so far, I'm really excited to see what we're finding here. And the study's ongoing, so I'm excited to present more of these results in the future. And further refinement is going to be really crucial here. So that's another part of the study that I am collecting feedback from just participants to refine the study. I'm not presenting that today, but I'm happy to speak more on that as well. So I want to thank my team here that been really involved in this research. I'll just note, this is just the team that is involved for these projects I've talked about today. But this takes such a labor of love from the team, including especially the therapists that do this work on a weekly basis. So I'm entirely grateful, and especially to funders as well, including the American Foundation for Suicide Prevention. So with that being said, I will go ahead and leave it here. I'm excited to hear our discussant speak about all of these studies and look forward to talking with all of you. Thank you.
I get the privilege of introducing our amazing discussant, Dr. Jessica Schleider. She is a founding director of the Lab for Scalable Mental Health and associate professor of medical social sciences and psychology at Northwestern University. Dr. Schleider also serves as director of digital services at Northwestern Center for Behavioral Intervention Technologies. Dr. Schleider's professional mission is to build, test, and disseminate scalable, evidence-based mental health solutions that bridge previously unfillable gaps in mental health ecosystem, with a focus on single-session interventions for underserved youth.
So I'm old. Fun. I'm super excited to be able to serve as a discussant for this incredible panel of very exciting research. I've been coming to ABCT for 11 years now, and this topic has been extremely underrepresented the entire time that I've been attending this conference. So the fact that there's this panel of amazing speakers. Yesterday we had a panel on stigma with psychologists, psychiatric disability histories. It's really exciting and new, and I hope to see more of this in the future. I'll share some general reflections and questions that I have no answers to, but I hope you all can do research to answer my questions in the future. So first of all, the theme that came through really strongly for me is that disability is not the risk factor, right? Ableism and oppression is the risk factor. This has been talked about again and again with respect to talking about race versus racism as a risk factor, and stigma against LGBTQ folks versus identity as a risk factor. And I think this idea was really nicely illustrated in Peyton's talk and Jennifer's talk, which speak to the benefits of a strengths-based approach to understanding disability identity and how that can be restorative, and kind of go against the stereotype that disability is itself a risk factor. And likewise, the disability for itself for the risk factor, Lauren, your intervention couldn't have worked, right? You can't treat with a psychosocial intervention approach if something is immutable. So that really emerged really strongly and nicely in all of the talks, I think. The concept of disability identity too, and its potential benefits for folks makes so much sense, and raises so many interesting opportunities for intervention design that's really more affirming and strengths focused than a lot of the approaches that have come before. And while this mirrors a lot of the literature coming out of other kinds of identity focused or affirming interventions, like for specific racial or ethnic groups or specific gender or sexual minority identities, disability identity is a little bit different because disability can be acquired, and other identities less so, right? It can also fluctuate over time. You can identify as disabled at one point and not in the future. This is especially true with psychiatric disabilities, which Sarah, I think, speaks to some of the complexity of the findings in your study, with people really not knowing how to talk about psychiatric problem histories in the context of labeling or not labeling as a disability. Probably has some intersections with internalized ableism as well, but we can certainly talk about that as a panel, and I'd love to hear your reactions to that too. Peyton, I was really struck by your work embracing the complexity that's inherent in the disability identity construct, which I think adds a really nice and important new dimension to this work. Given the fact that in 74% of your sample, people had an acquired physical disability, right? It's something that is necessarily multifarious and multifactorial. And the notion that some facets of disability identity can be associated with increased anxiety, increased social anxiety, and others can be empowering is so fascinating and clinically relevant, and suggests that, discussions and assessments of disability in clinical practice should probably go beyond yes, no, do you identify as disabled, but should really understand the various facets of how people relate to their disability and what they think about it. Other thoughts in no particular order. Sarah, your data were so interesting. What struck me in particular, in addition to the lack of consensus, I guess, with what people think or how they label their experience with psychiatric problems, diagnoses, disability, is that the percentage of disability identifying folks in graduate students was 25%, which matches, right, the 27% estimate for the population. For faculty, that dropped to 12, which shows the pipeline issues. And that discrepancy, I think, is a really valuable one to track in terms of,
are we really living up to our effort, our intentions to combat ableism in academia and our own field? I think seeing more consistency in that number, which there's no reason to suggest that it will be dropping to 12, I think that would be a really important target for the field to try to understand. I have so many other thoughts, but I also want to prioritize plenty of time for Q&A. Lauren, I just thought your study was so wonderful. It's so exciting to see this adaptations of interventions that weren't built for specific communities, weren't built to befriend specific folks, actually being effective and actually being promising. The idea of centering lived experience, Peyton, was also really clear in your talk when you kind of did this iterative process of first drawing from your own personal experiences, which I think is fantastic and so critical, because how else would somebody come to the idea, right, that this is such a multifarious identity construct, and then going back to folks with lived experience after you test your factor structure to see if this makes sense. So I really appreciated the attention to lived experience in both of those talks. All right, at this point, I'd love to open it up for questions.
Of this fantastic panel of folks, which I think I can record over here. Let's see. Yes, awesome. Who, identify with lived experiences relevant to the disability community. I realized I didn't mention that I have psychiatric disabilities. That's part of my personal experience. And so we really wanted to take some time to sort of leverage the experiences of these folks. So we had a couple questions to kind of start with that we thought might be of interest. And then we'll also open it up for Q&A. We have a mic here for folks that have questions. And if you want us to bring the mic to you, just raise your hand. But the first kind of general question we were thinking folks might want to talk about is, what's worked for you in terms of your own kind of needs in terms of accessibility and research and clinical practice in psychology?
Any kids? I guess I'll go first and see eyes on me over here. Okay, I'm not down here. Yes, okay. I think they're all, not sure. Okay. So for me, it's been quite a process to figure that out. And I think that's kind of why I paused on my pretty early career. I'm trying to figure out what are my needs. I think for me, a lot of things is larger text, accessibility, options on computers, things like that. So even like we discussed during this conference, can you use my computer, things like that. So that because I know how to navigate it. I find that it's not necessarily the things that I need that are kind of become barriers. It's other people's perceptions of what I can and can't do that have been kind of traditionally the issue in my research or clinical work. To give an example, and published a paper with Emily Lund and colleagues on this. Is sometimes there's an perception that if I'm struggling, it must be, or if I'm need help with something, it must be because she's blind. No, it could be that I'm just struggling to be a therapist, sometimes therapy is hard, or sometimes research is hard. Or the perception that, Lauren makes a lot of typos in her work, she must be careless. Lauren has a lot of manuscripts and is doing a PhD, so that's probably not the case. So that is, that's generally been the barrier for me is not necessarily figuring out what the access needs are. Because I generally mine, from my experience, they are minimal. It's navigating what other people think I need or can do. So thanks. That's a wonderful question. Really thought-provoking.
I think I would agree with that. Well, first of all, I'm super early in my training on the postdoc, so definitely we'll have this evolve, I'm sure, over time. But I think I would completely agree with that. I've been really lucky to have very supportive mentors and other people, collaborators in the field who have really helped me navigate the process and, really followed my own lead around my disability and started making those assumptions, which is extremely helpful. I think it can just be tricky, like navigating, requesting accommodations and those kind of things in the field, when I first got into it and stuff. And so it's been really helpful. I've received mentoring from someone who does have a disability, and that's been super helpful for just figuring out how to navigate the accommodation process, how to communicate with people. So I think that's been super helpful too. I'm sure, I agree with you a lot, on those just assumptions and stigma and stuff.
What's worked is a hard question to answer.
What hasn't? What
Yeah. So I also didn't mention positionality-wise, I'm a person with a history of psychiatric disability. And I didn't identify it as a psychiatric disability until I was informed that you could, based on the literal criterion, like what is written as the definition of disability. And as a result, I never sought accommodations. I just tried to hide it and try to overcompensate with showing, look how much I can produce, look how much I can do, to make sure that if anyone ever found out, they wouldn't be able to say, you can't do your job. So yeah, what's worked is difficult because I never navigated the system other than trying to circumvent any discussion of it whatsoever, which is a different kind of burden, and different kind of challenge than I think, folks who have more of a disability identity from the start are able to pursue. But definitely resonate with the idea of the main tricky thing being other people's perceptions of what you can and can't do, other people's expectations of how worse this could get, or what, going straight to the worst case scenario once they know certain things about your identity or history. So I guess my takeaway from all of that is nothing is working well in the academy, and these discussions are an important starting point to making sure that we don't see that drop from 25% to 12% in our own field.
Yeah, so I certainly think I haven't had kind of official accommodations through like HR or through student disability services or things like that related to my psychiatric disabilities. I do think about kind of accessibility needs for myself. There have certainly been points in my work where I said, like, I don't know if I can hang, like a lot of internalized stigma around, maybe I can't do this gig because of these challenges that I'm having. And one thing that my graduate mentor, sort of later in my graduate training, when I was more forthcoming with him about it, which again, stigma, et cetera, that sort of made that more challenging for the first kind of part of my training. He sort of reflected, well, yeah, academia is really hard, but, there's also some benefits to folks that maybe need or can benefit from having more flexibility, like academic, research ebbs and flows. And there's the ability to, in some ways, set my own schedule. Obviously not what sort of course you're teaching, but, I can do, I can have a therapy appointment in the middle of the day in my office, which I couldn't necessarily do, or I can take time off to go to a therapist's office and come back, but might be harder in a sort of more traditional 9-to-5 where I have to like log sick leave in a different way. So I think there's ways that I've sort of structured my work that help with allowing me some of the flexibility that's needed to account for the fact that my symptoms wax and wane, and therefore their impact on my work waxes and wanes. But I do think it is a really significant challenge, especially around faculty often don't have kind of their own disability services on campuses the way that students do. It goes through HR, and HR can be more or less effective. And relating to the kind of accommodations you might need. So I often get asked, well, what do accommodations look like for people with psychiatric disabilities? Well, that depends on the person with the disability. I did give you a broad answer. But those offices may be less familiar with kind of what might be options in terms of leaves of absence or a flexible schedule to attend specific kinds of treatment or things like that.
I will say the flexibility absolutely is immeasurably helpful in that you can set your own schedule around when you feel better or worse. It's also a bit of a challenge, especially for the formal help seeking piece, because a lot of the time, I don't know if you've experienced this, or you experience this, but there's you're pushed to do things very informally. So taking time off rather than logging time off, or taking a formal sick leave. Just do your work from home, or don't show up, or don't talk about it, and just figure it out. You don't have to make it on paper, right? That's something that I've experienced quite a lot. And I think it's seen as a kindness, but what it does unintentionally is prevent people from taking advantage of the leave they're entitled to.
I think our kind of next question was thinking about research strategies that folks have used to kind of ensure that your research methods are inclusive to folks with a range of disabilities. So I'd love to hear kind of what people thought about. I know, Lauren, you mentioned kind of adapting materials and things like that. Other thoughts that folks maybe have in terms of recruitment, study procedures, like how do we make sure that folks with disabilities are in obviously our disability-focused work, but also our other non-disability-focused work.
I guess I'll go first.
You don't have to if you don't want to.
Like, okay, so for me, the biggest thing that I've come to the realization that it's one is the easiest thing to do, and two, the most effective, sorry, let me move closer to the mic here, is to just ask people with disabilities what works. You're going to get a response, and you're going to get a good one, and it's going to be helpful. Because that's really what it comes down to, is deferring to the community, to what their needs are. So for recruitment, things like that, social media is huge, especially like disability Twitter, things like that, for recruiting, but also getting the perspectives of people with disabilities, and leaning into that. But certainly, for folks who have the funds to do so, the CDPR-based approaches are essential. So my work is moving more towards that. And to integrate that feedback into everything that I do, because the big thing in the disability community, or the big phrase, is nothing about us without us. And so that applies definitely to research too. If the work that we're doing, recruitment, our materials, things aren't accessible, they're not going to be reaching the people who need to reach. And from an intervention perspective, I'll be very frank. If that's not happening, and that those people aren't included in our trials, then our interventions are basically garbage, because they're not reaching the people they need to reach, and we're not actually having these efficacious interventions for the people who need them the most.
I completely agree with that. I think, I've done a few studies now where we've gone into that disability community and asked people, what do you think of these measures? What do you think of this study that we're doing? Is it meeting your needs? And the responses that we've gotten have been so helpful for, figuring out, does the scale that we administer to kind of the general population, is that actually capturing the construct that we're looking at specifically in people with disability? And so I think that feedback, like you were saying, has been so invaluable, even by, limited experience. I also think about dissemination. So I think in a lot of cases, research is not given back to the people that we ask for help, our participants. And so whether that be because the format that we're trying to disseminate this research is not accessible to people, or it's in a journal that requires, a subscription, things like that. And so one thing that I really want to do in my future research is to go back into the communities that we recruited from and, deliver our results in a way that's very accessible for them and empowering, and really include them as more of partners in the research, rather than just going in and taking information and not giving anything back.
I mean, I could go on about making things accessible and open access but let's not. But what I will say is that there are actually, Lauren, I love your point that interventions are garbage if we don't know who.
I appreciate that.
They are, because the people we're trying to serve with the highest levels of needs are continuously excluded from the studies we do, and therefore we have no actual idea if the interventions we've been testing all along are actually helpful for these marginalized groups, including but not limited to people with disabilities. And I'm just reflecting on Ariel, our recent experience with the IRB. And often disabilities, identity, having a disability isn't even measured in studies. So we have no clue the degree to which these people are represented or not in our research to date. And Ariel Smith, who's been great about bringing more focus in these diverse disability-related items into our research. Study that she's leading, we recently requested that the IRB allow us to simply ask if people have a disability. And the IRB disallowed that because that's a different kind of high-risk community. Like, let's not ask about suicide because then we have to do something about it, kind of thing. And it's just the systemic barriers to actually doing this correctly are really absurd. And by the way, we're very used to navigating IRB difficulties. We request parental consent waivers for all of our research with teens. They were fine with that, but we couldn't ask the teens if they had a disability. So I just want to highlight that it's not easy to do this work in the way that it should be done. That doesn't mean we shouldn't try, but anticipating and sharing about the barriers that you're experiencing and doing this work is a really important part of making progress.
I think my thoughts on this actually also lead into kind of our last just panel question about what can allies do to help improve access and inclusion in academia for trainees and colleagues with disabilities. Because I think my answer is the same or similar for both of these questions, which is really drawing on Lauren's, like, can you ask people what they need? I think a lot of times the assumption or the burden is placed on people with disabilities to sort of fight for what they need and to raise those issues and to bring that up. And that's an extra layer of stress that shouldn't be required. I mean, not to poke a little bit at the conference that we are at, but we learned in trying to find out about what disability accommodations were available that the accessibility page for the conference only went up live like a week or two before the conference. And basically the accessibility page said, email this person and they'll find out what we can do for you. As opposed to saying, these are the accommodations that we kind of have already ready to go. And if you need something else, let us know, having a streamlined way to do that. I think for people with disabilities and for allies to really kind of prioritize and think through, well, what can we do from the start to, have multiple methods for people to access information, for people to participate in our research, for people to be in our training programs, what aspects of what we're asking people to do are necessary. Like, you have a cognitive computer task in your study that requires someone to look at an image on a screen for the specific variable you're measuring versus, well, I just assume everybody will have corrected to normal vision. And so I haven't thought about how I would adjust it. Like, you need to be proactive, both for your colleagues, your trainees, and your participants. I'd love to hear what other folks on the panel think that allies can do in terms of kind of supporting trainees and colleagues.
I think at a very basic level, like the easiest thing is to just take some time to learn from the rich information that is out there from the disability community already. There's documentaries. I always plug Crip Camp. If folks haven't seen it, it really goes into the disability rights movement, learning about the history behind that. Learning about the perspectives of people in the disability community on various topics. Lots of readings. Alice Wong's Disability Visibility Project. I plug that quite a bit too. It's not that the disability community doesn't have anything to say, it's that people aren't paying attention or quite frankly aren't listening. So from the easiest thing that people can do from a disability 101 perspective is to just look up resources, sit down and take some time to just learn before, speaking up. So listen first.
I feel like everybody has already said what I was going to say, but I think, one thing that I have been thinking a lot about this past year is, accessible kind of presentation styles. So one thing that's hard for me, I didn't mention, but I have hearing loss in addition to some muscle weakness. And one thing that's really tricky for me is Q&As, because oftentimes I can't hear the audience question if it's not amplified. And so, I know Sarah mentioned a minute ago that we're going to ask you all to use the mic, and that's really to increase accessibility for people like me who have hearing loss, but then also just everybody else in the audience as well. So I think that there's a lot of practices like that too that can really go a long way in not impeding the presentation for anybody else and really just making it more accessible for everybody.
I think we've got about 7 minutes for questions. If the mic is on, if folks want to come up and ask a question, or if you want me to bring a mic to you, I'm happy to do that as well. Sorry, it's very tall. I'm just realizing right now.
Okay. So thank you guys so much for doing this. This is fantastic. I've talked to Dr. Pearlstein previously about how she's received phone calls from directors of clinical trainings previously after they've received a new, for example, blind student in their cohort. And they say to her, well, what am I supposed to do about this? So we can have conversations like this, and we can try and increase allies. But what do we do with people who don't want to have the conversation?
Those people should not be DCTs.
Yeah, I agree. What do we do with that?
Yeah, I honestly think that the onus is on whoever is in the environment with these people to I don't think it's the responsibility of the folks who have less power to say that is an unreasonable question and you need to go to your campus accommodations. I think that ideally should be someone working with that DCT to say, hey, I understand why you are trying to figure out how to handle this, but there's actually legally, there's gotta be, somebody in your setting whose job it is to help you figure this out. And it shouldn't be on just the blind person that you happen to know to expect them to do your job for you. I mean, I'd hopefully say it in a slightly more polite way if it were my colleague, maybe. But that's my thought is we actually know how to provide a lot of these accommodations. People just need to go to the right office not that getting them or doing them is easy, but from the DCT's perspective, they don't have to start from scratch.
Yeah, it seems like bare minimum for a DCT to be able to do. But in terms of things that allies can do, intervene on that.
Yeah.
Overhear that conversation and say something about it. Say you're putting the onus on the wrong person here. This is not how this should work. There's an entire office that is dedicated to making sure that people get what they need to access whatever they need to do their job or be at school. So I would say that's a great opportunity for ally involvement to demonstrate allyship. Yeah.
I'll sorry that it's so loud, from the kind of blind perspective as well, mention, first time looking at blind boils, knowing Dr. Pearlstein is a great colleague, that hearing she has to deal with that as well. Not surprised. But I find that the attitudes that I've experienced personally, 99% of them are not as horrible as the way you described it. And I totally 100% believe that is happening. So to kind of tack on to the great comments we had before, the attitude I found is more we don't know what to do with you and we're willing to help, but we're kind of clueless. But when I was in training, grad student in particular, in a low resource program setting, that led me to just shut up. I need an accommodation on, this software for computer, but I know it's going to make the computer crash and it's going to cause problems. So I'm just going to sit here and sit an inch from the screen to write all my reports for, 4 or 5 years. So I would say even it's a very more sneaky type of ableism that was experienced in my lab program, and the nicest people. But yeah, the idea is we don't know what to do with you. Can you teach us? Or kind of just skirting around the issue that as a student just made me shut down and just take it. However many migraines that caused. So from an ally perspective, just being mindful of looking out, taking a look out for that as well. This idea that like, we don't know what to do, so we're just going to throw our hands up. Wonderful question, but also really unfortunate.
First things, I just want to say thank you for everybody sharing, like on the panel and stuff like that. I'm really glad to see a panel like this at ABCT. In the similar vein of like talking about accommodation more, and I really found it interesting, like the impact of like startups in this. And there's kind of like a hidden curriculum of what accommodations can I ask for. And I think that is something that like is a concern for me as a trainee going into and then hearing about like that DCT's experience. What are some of your thoughts on how principal trainees are going to serve folks?
That is $1 million question. And something I've struggled with even until recently. So I'll say I've been on job interviews where I was basically put in a position where I've had to disclose. And like, I didn't want to, but they basically put me in a position. They knew what they were doing here to make me disclose. And then I had to say, oh, but I don't need that many accommodations. It's not that bad. It's minimal. Please hire me. Because that concern that I would be so much of a burden that like the job opportunity would be gone, no matter like what my CV looked like. So it's tough from my perspective because also I'm a research track. I'm not on the tenure track. I have no power basically. From a personal perspective, I do have more power now that I can advocate for younger folks, younger being, use that term loosely in terms of like career stage, where I would be very angry if I saw something like that happening. I've mentioned things like this happening to people in power. That's kind of from my perspective, but someone with limited power. Unfortunately, a lot of times the best I can do, and it really stinks.
I think that one thing that can sometimes be beneficial is like really seeking out folks who can give you sort of an unfiltered perspective, right? Because if you go to like the official sort of accommodations websites for universities and things like that, they're going to say that we can accommodate everything. And whether that is actually true or how easy that is, looks very different at different places. And so to the extent that you're aware of, faculty with disabilities or students at programs with disabilities, to, them sort of thinking about this in like the, grad admissions process or searching your job search process, to say like, hey, you're here, like, how's the accommodation process been? And I hate suggesting it because again, that's more labor on the folks who have disabilities, who have them disclosed or other people are aware of them, to do this sort of informal like mentoring whisper network thing. But I also don't know that there's like a better way to get some of that kind of on the ground information about how tricky it is to navigate at a specific place. Otherwise, right? And I think to the extent that there are more faculty who are saying, yes, I have these disabilities, like I would be more than happy to answer people's questions about that or to connect folks with other resources in our institution. That's my thought.
I think something else that came up in our panel yesterday was just the importance of transparency, right? Like when the programs are trying to recruit new cohorts of students, they do an intro to the overall program and what its features are and what's available to students. More often than not, that doesn't include any mention of how accommodations work at the institution, how students are supported in the needs that they have. And I think in terms of how can we better support students, the onus is really, I think, on programs to just be direct and upfront with the information. And I think that alone, just sharing it, organizing it, making it known, is a step beyond what most programs are doing right now. And at least demonstrates an awareness at baseline of the fact that 25% of their students are going to need this. So it's relevant to go over.
Or even to kind of to say, like, as I was thinking about like the ABCT example, to say like, obviously, you have your section in the handbook about access to student disability services, but then to even say like, accommodations that we've been able to provide in the past, obviously in a de-identified way that's not relevant, that we know how to handle getting screen reader software. We know how to handle, we can answer your questions about
physical access, for wheelchair or, scooter users or any kind of mobility device like that. At least the programs can say like, hey, we have some knowledge of how to handle these specific things, and other things we will work with you to figure out. Right, that we've had some success, hopefully, in doing it. That we're not going to have that sort of blank stare of like, oh gosh, well,
Yeah, exactly.
I think could be a good place to start. Also realize I don't know if you think about the thoughts, we're a little over time. All right, well, we are at 10:03. Thank you all so much for being here. I'm really just thrilled to have everybody here talking about this important stuff. And what I'm thinking is if you want kind of the link to the recording and slide decks, if you want to come up and I can type up everybody's emails, that way I don't have to try to kind of read. And I also don't actually have a pen, so we'll do that way if you want slide decks and links and stuff like that. And I think we could also probably put a list of some of the resources that we've mentioned when we distribute that as well. So thank you so much.